Hello again, students. Here we are going to cover the brain and the cranial nerves, which will be in chapter 14. The brain is vital to our existence. It controls our voluntary movements and regulates involuntary activities such as breathing and heartbeat. The brain serves as a seat of human consciousness. It stores our memories, enables us to feel emotions, and gives us our personalities. In short, the brain dictates the behaviors that allow us to survive and make us who we are. The brain has been assigned major landmarks. Two directional terms are rostral, which means towards the nose, and caudal, which means towards the tail. The brain can be divided into three major portions. We have the cerebrum, the cerebellum, and the brainstem. When we take a closer look at the cerebrum, it is about 83% of the brain's volume and consists of two cranial hemispheres, our left and our right. It also contains various structures such as the gyri, the sulci, and the longitudinal fissure, and the corpus callosum, which we'll explain a little bit later. Now, the cerebrum is the second largest region of the brain, constituting 10% of its volume, but containing over 50% of the brain's nerves. It occupies the posterior cranial fossa inferior to the cranium. The brainstem is what remains of the brain if the cranium and the cerebellum are removed. It has major components from the rostral to the caudal. They are the Diencephalon, Midbrain, Pons, and the medulla. So when we look a little further at the cerebrum, you see that it contains a longitudinal fissure. The longitudinal fissure is that deep groove that separates the left and right hemisphere. The gyri are the thick folds that you see on each of the hemispheres. And the sulci are the shallow grooves which are going to separate the gyri. Now the hemispheres need to be held into place, and they're held into place by the corpus callosum. And they're held together at the bottom of the hemispheres. Now, the brain, just like the spinal cord, is composed of gray and white matter. Now, white matter, as you see here, is that bright pearly white color. And is that color due to the myelin around its nerve fibers. Now, the gray matter, which you see on the outer aspect, it has little myelin and is a duller white color. And the gray matter, it forms a surface layer called the cortex over the cerebrum and the cerebellum. Now the white matter has nuclei, which are these deep masses that are going to surround it. Now in the brain, the white matter lays deep in the cortical gray matter, opposite from their relation in the spinal cord. So I hope you guys remember that the spinal cord, when you look at the spinal cord, the gray matter is in the inside and the white matter you'll find on the exterior. Now the white matter in the brain is composed of tracts or bundles of axon. Now the brain is enclosed in three connective tissue membranes called the meninges, and they lie between the nervous tissue and the bone. The three membranes of the meninges are the dormata, arachnoid matter, and the pia matter. And they're there to protect the brain and provide structural framework for its arteries and the veins. Now, in the cranial cavity, the dormata consists of two layers: the outer periosteal layer and the inner meningeal layer. Now when we look at the two, you can tell that where they the direction that they will go and what they will cover is slightly different. The periosteal, it is equivalent to the periosteum of the cranial nerves. And of course, what it will do, it will cover, or it will outline the brain, and covering the whole aspect of the brain from the superior end all the way to the lateral aspect of both sides, or both lateral ends of the brain. Now the meningeal layer, that's the one that's going to continue into the vertebral canal right in here, where it's going to form the dorsal sac. So it doesn't, when you reach to that small section here at the posterior end of the brain, you're going to have the meningeal layer branching off and dipping between the two hemispheres, okay? And that's that protection layer between the two. Now the dura mater as a whole is pressed closely against the cranial bone, but it is not attached except in limited places, such as the foramen magnum, the sella turcica, and the crista galli, and also where some sutures. Now the cranial, also there is no epidural space in the dura mater. Now, in some places, the two layers of the dura are separated by dura sinuses. You have the superior sagittal sinus, and that's found just below the cranium under the medial line. Then we have the, as you see here, the superior lateral sinus right below the cranium underneath the sagittal line. The medial line, sorry, and then you have the transverse sinus. In this diagram, you see that straight sinus, but that's the one that runs horizontally from the rear of the head toward each ear. Now these sinuses, they meet like an inverted T at the back of the brain and ultimately empty into the internal jugular veins. Now in certain places, the meningeal layer of the dura folds inward to separate major parts of the brain. We have the phalanx cerebra, which separates the two cerebral hemispheres, which you'll find right here. Then we have the tentorium cerebelli, which you're going to separate, which is like a roof over the posterior cranial fossa, and is going to separate the cerebellum from the cerebrum, which you'll find right here. This small little flap you see right here, that's our tentorium cerebelli. Then of course we have another one, our third one here, which is our phalanx cerebelli, which separates the left and the right halves of the cerebellum. So we have three major folds. Let's go over that again. We have the phalanx cerebelli, which separates the left and right cerebral hemispheres. So pay attention to the name. That will actually help you in remembering them. The second word in the name, the tentorium cerebelli. Tentorium cerebelli, that runs horizontal, and that's going to separate the cerebrum from the cerebellum. Then we have the phalanx cerebelli, which will separate the left and right halves of the cerebellum. Now, the arachnoid matter and the pia matter are similar to those of the spinal cord. The arachnoid matter is a transparent membrane over the brain surface. The subarachnoid space, it separates it from the pia matter below. Now, in some places, the subdural space separates it from the dura above. So here we have the subdural space, subdura, that's going to separate it from the pia, sub meaning below. So to help you remember, sub meaning below, so that's below the arachnoid. And what space, what meninges is below that? You have the pia mater. Then we have this dura space, sub meaning also below, but it's below the dura. So the subdural space would be below the dura. So it's between the dura and the arachnoid space. Now the pia matter is a very thin, delicate membrane that follows all contours of the brain and the sulci, and is not usually visible without a microscope. Now the brain has 4 internal chambers called the ventricles that are filled with cerebral fluid. So here we have a picture of exactly what they would look like within the brain. Here we have the lateral. We have 2 lateral ventricles. We have a 3rd ventricle, and we have our 4th ventricle. You can see the 3rd one a lot better over here, and the 4th one as well. So we have 2 lateral ventricles, 1 3rd ventricle, and 1 4th ventricle. Now the largest and the most rostral are the lateral ventricles, which form an arc in each cerebral hemisphere. The lateral ventricles, they connect to the 3rd ventricle, a median space inferior to the corpus callosum, via this particular interventricular foramen, and it has a tiny pore. It's a tiny pore that connects the 2 lateral ventricles to the 3rd ventricle. Now, a canal called the cerebral aqueduct, it leads the 3rd ventricle to the 4th ventricle, and it's a triangular chamber between the pons and the cerebellum, that 4th ventricle. The 4th ventricle, it allows, it narrows caudally, means narrow to the back, it starts to narrow out, to form a central canal that extends through the medulla oblongata into the spinal cord. So here we take another look at our lateral ventricle, and here is the 3rd ventricle, and of course our lateral again. So you know it's a cross section of the cerebrum. Now each ventricle has a mass of blood capillaries on the floor or the wall called the carotid plexus. Okay. Now the ependymon. So the ependyma is a type of neuroglia that resembles cuboidal epithelium. It lines the ventricles, as we see here. They're going to line the ventricles and the canals, and then it's going to cover the corpus plexus. And these are the ones that are going to produce our CSF, which is our cerebrospinal fluid, the epithelial cells, or the epidemia. Now, the cerebrospinal fluid, which I'll refer to as the CSF, is a clear, colorless fluid that fills the ventricles and the cranium and the canals of the CNS, and is going to bathe its exterior surface. The brain produces about 500 milliliters of CSF per day, but is it is consistently reabsorbed and only 100 to 160 milliliters is normally present at one time. The CSF production begins with filtration of blood plasma through the brain's capillaries. The epithelial cells, they modify this filtrate so that the CSF has more sodium and chloride, but less potassium, calcium, and glucose, and very, very little protein. Now, the CSF is circulated through the CNS by its own pressure, by the beating of the cilia on the epithelial cells, and by rhythmic pulsations of the brain produced by the heartbeat. Now, how does the CSF even flow through and circulate throughout the brain and down through the spinal cord? Well, we have step one. What happens in step one? Well, we have the CSF. It's secreted by the choroid plexus, which you find within the lateral ventricle. It flows through the interventricular foramina, which is those small little pores, small little spaces. It's mostly through that foramina into the third ventricle, into the third ventricle, which we have right here. And then at this point here, we have more choroid plexus, and they're going to add more CSF. When more CSF is added, the CSF is going to flow down the cerebral aqueduct to the fourth ventricle. So there's an aqueduct here, and it's going to flow down to our fourth ventricle. In the fourth ventricle, you'll find more choroid plexi. Now in there, of course, they're going to add more cerebral fluid, cerebrospinal fluid. At this point in time, the CSF is going to flow out through two lateral apertures and one medial aperture. So it is flowing through here. At this point in time, the CSF is going to fill the subarachnoid space and is going to bathe the external surfaces of the brain and the spinal cord. Now, the CSF is then reabsorbed by the arachnoid granulations protruding through the dormata into the superior sagittal sinus. So here it is going through the arachnoid space and the and the dormata, bathing the entire brain. And here are our arachnoid villi, which are going to help reabsorb the CSF into the venous blood and of the dormata. Okay. So here is the description here, or the various steps involving how cerebrospinal fluid circulates and is produced throughout the brain. So hopefully you guys have printed off the PowerPoint and you guys will have this for your own notes. Now, the CSF serves three functions, or three purposes. You have buoyancy, protection, and chemical stability. With buoyancy, the brain and the CSF are similar in density. This buoyancy allows the brain to attain considerable size without being impaired by its own weight. For protection, the cerebrospinal fluid helps prevent the brain from striking the cranium when the head is jolted. So if someone starts to shake you, or you get hit, this cerebrospinal fluid helps to protect the brain from major damage. Now, of course, if you're shaken extremely hard, very severe, or jolted very severely, it can cause damage to the brain, because there's only so much that the CSF can handle. And of course, that's when you have shaken baby syndrome, or even concussions that someone may get from an accident or boxing, or even from football, which everybody's talking about now. And our third function is the third function would be chemical stability. When we have the flow of the CSF, it rinses out any type of metabolic wastes away and try to get things back in the brain's chemical environment back to a homeostatic level. Alright, so the blood supply to the nervous system is critically important, and the brain barrier system protects the brain from harmful agents in the blood. The brain is only 2% of the adult weight, but it receives 15% of blood and consumes 20% of oxygen and glucose of the body. A 10-second interruption in blood flow can cause loss of consciousness. 1 to 2 minutes impairment of function, and 4 minutes will cause irreversible brain damage. Now, the brain barrier system, it regulates what substances can get from the bloodstream into the tissue fluid of the brain. Those 2 points of entry, are the blood capillaries through the brain tissue and the capillaries of the core plexus. Now, the first one, the blood capillaries through the brain tissue, of course, it is protected by the blood-brain barrier, also called the BBB, and consistent of tight junctions between the endothelium cells that are going to form the capillary walls. The capillaries, the second point of entry, are the capillaries of the core plexus, and it is there protected by the blood cerebrospinal fluid barrier formed by the tight junctions between the ependymal cells. So when we look at the blood-brain barrier, that protects the blood capillaries through the brain tissue. Consists of tight junctions between the endothelium cells that form the capillary walls. It has astrocytes that reach out and contact the capillaries with their perivascular feet, which we talked about earlier. And then they induce the endothelium cells to form these tight junctions that completely seal off gaps between them. And anything leaving the blood must pass through the cells and not between them. So it must pass through and not between. The endothelium cells can exclude harmful substances from passing into the brain tissue while allowing necessary ones to pass in. Now, the blood CSF barrier that protects the brain at the choroid plexus, which we know we'll have them in the 4 ventricles, brain ventricles. They form tight junctions between the endothelium cells, and the tight junctions are absent from the ependymal cells anywhere else. And they're important to allow exchange between the brain tissue and the CSF. The blood-brain barrier is highly permeable to water, glucose, and lipid-soluble substances such as oxygen, carbon dioxide, alcohol, caffeine, nicotine, and anesthetics. They do have a slightly similar permeability to sodium, potassium, chloride, and the waste products, urine, and creatine. Let's look at a few diseases involving the brain barrier the blood-brain barrier. We have meningitis, which is the inflammation of the membranes that surround the brain and the spinal cord. Now, when the meninges are inflamed, the blood-brain barrier may be disrupted. Now, this disruption may increase the penetration of various substances, including toxins or antibiotics, into the brain. We have epilepsy. It's a neurological disease that is characterized by recurrent and sometimes untreatable seizures. Several clinical and experimental data have implicated the failure of blood-brain barrier function to trigger chronic and acute seizures. These findings suggest that acute seizures are a predictable consequence of disruption of the BBB, which is a blood-brain barrier, by either artificial or inflammatory mechanisms. Then we have MS. Multiple sclerosis is an autoimmune neurodegenerative disorder in which the immune system attacks the myelin that protects and electrically stimulates the neurons of the CNS and the PNS. However, we have the MRI has been shown that when a person is undergoing an MS attack, the blood-brain barrier has broken down in a section of the brain or the spinal cord, allowing the white blood cells, called the T lymphocytes, to cross over and attack the myelin. Now we have Alzheimer's disease. Some new evidence indicates that disruption of the blood-brain barrier in Alzheimer's disease patients allows blood plasma containing amyloid beta to enter the brain, where the amyloid adheres preferentially to the surface of the astrocytes. So now we're looking at the embryonic development of the brain. And of course, after what it produces a mature brain anatomy consisting of the forebrain, midbrain, and the hindbrain. Now, of course, by the 4th week of development, the neural tube has formed and closed, and it separates from the outer ectoderm. So at 4 weeks, we're going to have the forebrain, the midbrain, and the hindbrain. Using these particular terms right here. By 5 weeks, the forebrain, the proencephalon, that is going to separate into 2 distinct sections, which would be our telencephalon and our diencephalon. The midbrain, the mesencephalon, would stay the same but develop a little bit more, and then the rhombencephalon will divide into the metencephalon and the myelencephalon. But of course, when it reaches birth, these regions are fully developed and are considered to be the cerebrum, the diencephalon, the mesencephalon, the cerebellum and pons, and the medulla oblongata. So what do we have? So the forebrain consists of the telencephalon, the diencephalon. The telencephalon at childbirth is formed into the cerebrum. The diencephalon, we have the thalamus, the epithalamus, and the hypothalamus. And the epithalamus consists of 2 areas, which is the pineal gland and the hypothalamus. The midbrain is considered to be the mesencephalon, and the midbrain are the metencephalon and the myelencephalon. The metencephalon is broken down to, or divided into 2, which I mentioned earlier, the cerebellum and the pons, and the myelencephalon makes up our medulla oblongata. So let's look at the forebrain. The forebrain, I said earlier, has the telencephalon and the diencephalon, which is the cerebrum, the thalamus, hypothalamus, and the epithalamus. So the telencephalon, we have the cerebrum, which we mentioned earlier on in the lecture. It's a major part of the brain, occupying at least 80% of the brain, and it deals with controlling emotions, hearing, vision, speech, and language, and also functions at the center of sensory perception, memory, thoughts, and judgment. The diencephalon, which is the interbrain, it encloses the 3rd ventricle. Now, the rostral parts of the brainstem will be the thalamus, hypothalamus, epithalamus, which consists of the pineal gland and the habenula. Now, in the cerebrum, it consists of 4 lobes. Well, 5 lobes. Before we were taught it was just 4 lobes. Now they've discovered there's another lobe inside. So the frontal lobe, as you see, is more in the rostral region, and that deals with voluntary motor control. It's a site of higher cognitive function. We're dealing with motivation, foresight, memory, motion, social judgment, and aggression. And of course, it has the largest structures of the brain and is associated with numerous disorders such as bipolar disorder and ADHD. The parietal lobe, as you see, is in the caudal region. It receives and integrates general sensory information, taste, and some visual processing. Deals with spatial mapping, and number representation. And we have our occipital lobe. Occipital lobe is the primary visual center of the brain, located here in the posterior region. It receives projections from the retina via the thalamus to encode different visual information such as color, orientation, and motion. The temporal lobe, located here on the sides, on the lateral sides, on the lateral aspects. Those are areas for hearing, smelling, learning, memory, and some aspects of vision and emotion. And then our last one, our insula, which is hidden between these regions. It's there for understanding spoken language, taste, and sensory information from the visceral receptors. So let's take a look at the Diencephalon region. So that was the first region, the Telencephalon. Now we're looking at the Diencephalon, dealing with the thalamus, hypothalamus, and the epithalamus. So let's look at the thalamus. Here we see is an ovoid mass on each side of the brain. See it right here. It constitutes about 4/5 of the Diencephalon, and it has two thalami, which are joined mutually by a narrow intermediate mass, and is composed of at least 23 nuclei. It's considered to be 5 major functional groups. It's a gateway to the central cortex. Nearly all input to the cerebrum passes by way of synapses in the thalamic nuclei. It filters information on its way to the cerebral cortex. It plays a role in motor control by relaying signals from the cerebellum to the cerebrum and providing feedback loops between the cerebral cortex and the basal nuclei. Is also involved in memory and emotional functions of the limbic system, which is a complex structures that includes some cerebral cortex of the temporal and the frontal lobes and some of the anterior thalamic nuclei. Thalamus deals with sight, hearing, taste, and touch. The hypothalamus. It forms part of the walls and the floors of the third ventricle with a variety of functions. This is the control center of everything. It extends anteriorly to the optic chiasm and posteriorly to the paired mammalian bodies. And these bodies, they contain at least 3 or 4 nuclei, which relay signals from the limbic system to the thalamus. It has a stalk that attaches the pituitary gland to the thalamus. Here's the stalk right here, and it's called the infundibulum. Infundibulum, I'm sorry. These words are tongue twisters. Now, major control. This is considered the major control center for autonomic nervous system and the endocrine system. Most important functions is linking the nervous system to the endocrine system. And this, of course, hypothalamus is there to regulate homeostasis in all of the body systems. So everything has to go to the hypothalamus in order for homeostasis to be regulated. So if your blood pressure is high, information has to be sent to the hypothalamus for it to lower. If you're sweating excessively and you're losing a lot of electrolytes, it goes through the hypothalamus so that things can be regulated properly. Okay. Functions of the hypothalamic nuclei. Hormone secretion. It controls the anterior and the pituitary gland in which it secretes 2 hormones, the follicle stimulated hormone and the LH, and it's there to regulate growth, metabolism, reproduction, and stress responses. It has autonomic effects. the major integrating center for the ANS. It acts as a control system functioning largely below the level of consciousness and controls visceral functions. The ANS affects the heart rate, digestion, respiratory rate, salivation, perspiration, and micturition, which is of course urination, and sexual arousal. Now, their autonomic effects deals with increasing the heart rate, blood pressure, gastrointestinal secretions, and motility, all through the descending fibers. Now, another function would be thermoregulation, in which the nuclei are going to regulate the temperature of our body. If it gets too hot outside, it'll send signals. If our body's too hot due to the heat or any type of fever we may have, those signals are sent to the hypothalamus to lower our temperature. And if it's too if it's too cold, then of course it's going to adjust the body so that we can react accordingly. Some more functions: food and water intake. We're going to look at hunger and satiety. It centers monitor the blood glucose and amino acid levels. It produces sensations of hunger and of course fullness. Now, the third center monitors the osmolarity of the blood. Another function, rhythm of sleep. It controls our circadian rhythms of activity. Memory. Information is relayed from the hippocampus, from the nuclei. And then emotional behavior and sexual response. We have anger, aggression, fear, pleasure, and contentment. Now, the last one in our Diencephalon is our epithalamus. The epithalamus is very, very small. Small mass, and it contains these two structures, the pineal body and the habenula. The pineal gland is part of the endocrine system. Also, the hypothalamus is part of the endocrine system, and the habenula receives relays from the limbic system to the midbrain, and it lays right here on a tiny roof over the third ventricle. Alright, so now we're gonna look at the midbrain, the mesencephalon. Now, it consists of short segments of brainstem that connects the hindbrain to the forebrain. It contains the cerebral aqueduct, and it contains continuations of the medial lemniscus and the reticular formation. It also contains the motor nuclei of two cranial nerves that control the eye, which is the oculomotor nerve, our CN3, and our tracheal nerve, our CN4. Now, it has these particular regions called the tectum, which you see here. It's a roof-like part of the midbrain superior to the cerebral aqueduct, which means it's above the aqueduct, and it exhibits four bulges: the corpora quadrigemina, and the upper pair, the superior colliculi. They function in the visual attention, which are these two right here, the visual attention, tracking moving objects, and some reflexes. The lower or the inferior colliculi, they receive signals from the inner brain and relays them to other parts of the brain, especially the thalamus. Also in the midbrain, we have things called the peduncles. And those are stalks that anchor the cerebrum to the brainstem, which we have here. And then anteriorly to the cerebral aqueduct. Now there are three main components. We have the first one we'll deal with is the tegmentum. The tegmentum is dominated by red nuclei, which you see in this region here. Of course, you can't see the color with this particular diagram, but its pink color is due to the high density of red blood cells. And connections go to and from the cerebellum, and they're going to collaborates with the cerebellum for minor motor control. The second structure is our substantia nigra. This is dark gray to black nucleus pigment with myelin. It is the motor control center that relays inhibitory signals to the thalamus and basal nuclei, preventing unwanted body movements. So if you don't want to go left, you have signals, those motor signals that prevent you from going left. Or if you're nodding in church, I get that description in church, the description in class one time, like if someone is in church or sleeping somewhere and they start to nod forward to prevent them from falling, that reaction from the motor center prevents them from falling forward, and that's coming from the substantia nigra. Now if we have deterioration of the neurons, it's going to lead to tremors of Parkinson's disease. Then we have cerebral crus. Now in this diagram it says crus cerebri, but it's the same thing. This bundle of nerve fibers that connect the cerebrum to the pons. Okay, and it carries corticospinal tracts. So here we have another diagram of the three. We have the tegmentum, which is this area here. We see the pinkish color now. Then we have the substantia nigra, which is that dark gray, sort of black pigment, which carries the myelin. This one doesn't have the myelin. And then we have the cerebral crus, or crus, sorry, cerebral crus, in that outer region. Now we're into the hindbrain, the metencephalon, and the myelencephalon. We'll talk about the cerebellum, pons, and the medulla oblongata. So we're starting with the medulla. We're going to look backwards this time. Alright, so in the embryonic stage, the myelencephalon, it becomes the medulla oblongata, and it begins at the foramen magnum of the skull. It extends for about 3 centimeters rostrally and extends at a groove between the medulla and the pons, and it's slightly wider than the spinal cord. Now it consists of pyramids, which are a pair of external ridges on the anterior surface, and it resembles side-by-side baseball bats. Let's see if it's here. I'll show you guys there in a second. Now the pyramids contain descending fibers called the corticospinal tracts, which carry motor signals to the skeletal muscles. It also has an inferior olivary nucleus, which relays signals which is a relay center for signals to the cerebellum. It has a reticular formation, which is a loose network of nuclei extending throughout the medulla, pons, and the midbrain, and that contains the cardiac, vasomotor, and the respiratory centers. Vasomotor, do you know what that is? Vasomotor deals with the vasodilation and vasoconstriction of the blood vessels. So here we have the medulla. And you see the pyramids, they do look like two baseball bats side by side. Okay. Green area, this is the medulla, this dark green area. Now the olive, which you see here in this area, it's a prominent bulge lateral to each pyramid. You can see here. Okay. Posteriorly, we have the gracile and the cunate fasciculus, which are tracts of the spinal cord. They continue as two pairs of ridges on the medulla. Now all nerve fibers connecting the brain to the spinal cord pass through the medulla. We have four pairs of cranial nerves that begin or end in the medulla. We have CN 9, 10, 11, and R12. Now, we have some centers that are involved with the medulla. We have the cardiac center, the basal center, respiratory centers, and the reflex centers. The cardiac centers, that's going to adjust the rate and the force of of the heart. The vasal motor centers are going to adjust the blood vessel diameter, so that's vasodilation and vasoconstriction. Respiratory centers that control the rate and the depth of breathing. And then our reflex centers, we're looking for coughing, sneezing, gagging, swallowing, vomiting, salivation, sweating, and movements of the tongue and the head. Now we're on to the pons. Can you see where the pons is located? Here's our medulla, and here's our pons. The Diencephalon, it develops into the pons and the cerebellum. The pons is the anterior bulge in the brainstem, right here, and is rostral to the medulla. The cerebral peduncles, they connect the cerebellum to the pons and the midbrain. It contains ascending sensory tracts and descending motor tracts, and this will help with pathways in and out of the cerebellum. Cranial nerves 5, 6, 7, and 8 are connected to the pons. It deals with sensory roles and motor roles. With sensory, deals with hearing, equilibrium, taste, facial sensations. And for the motor roles of those nerves, we have eye movement, facial expressions, chewing, swallowing, urination, and secretion of saliva and tears. Now the reticular formation in the pons, it contains the nuclei, and it's concerned with sleep, respiration, and posture. Now the largest part of the hindbrain and the second largest part of the brain as a whole is our cerebellum, which we mentioned earlier on in the lecture. It's considered to be, another name for it is considered to be the little brain, and extends from the rear of the brainstem. It consists of a right and left hemisphere, and is connected by something called the vermis. Here it is right here. Hopefully you guys remember the meninges. We talked about the meninges that separate the left and right hemisphere of the cerebellum, which is the phalanx cerebelli. Remember, you're going to be quizzed on it. And the cortex of gray matter with folds, which is called the folia, and 4 deep nuclei in each hemisphere. So here are the folia. These cute little folds in here. It contains more than half of all brain nerves, about 100 billion. Now the white matter branching is called the arbor vitae. We look a little closer at the peduncles. There are 3 pairs of stalks that connect this cerebellum to the brainstem. So here we have these stalks here, connecting the pons to the cerebellum. So this is a great view of exactly what it looks like. Great diagram, I say. We have an inferior, we have a middle, and we have a superior. With the inferior, it's going to connect to, it's connected to the medulla. Let's see this net working. Here we have the inferior, and it's connected to the medulla. And most spinal input enters the cerebellum through the inferior peduncle. Our middle peduncle, that connects to the pons. Come on. Here's the pons here. And we have our middle peduncle. And most input from the rest of the brain enters by way of the middle peduncle. Then we have the superior peduncle. It connects to the midbrain, and it carries the cerebellar output. Now, all of it consists of thick bundles of nerve fibers that carry signals to and from the cerebellum. So all of them are going to have these nerve bundles. Cerebellum monitors muscle contraction and aids in motor coordination. When we deal with evaluation of sensory input, deal with comparing textures without even looking at them. We have spatial perception and a comprehension of different views of 3-dimensional objects belonging to the same object. We do it timekeeping center. It has a timekeeping center where it's predicting movements of various objects. It helps predict how much the eyes must move in order to compensate for head movements and remain fixed objects on an object. Can you think of a particular disorder that may come into play when you're thinking about moving objects and making sure that your eyes are moving as fast as the particular object and not causing any type of dysfunction? I can think of vertigo. Vertigo would be a good example of timekeeping, where your eyes are not keeping up with how fast objects are moving, which would cause you to lose your balance. Then we have hearing. Hearing, we have distinguished pitch and similar sounding words. We have planning and scheduling tasks. And we have lesions may result in emotional overreactions and trouble with impulse control. Some other functions, we have influences memory and learning, and coordinates voluntary movement and balance. Now I've mentioned the reticular formation, and it's a region in the brain that is involved in multiple tasks such as regulating the sleep-wake cycle and filtering incoming stimuli to discriminate irrelevant background stimuli. It's a loosely organized network of gray matter that runs vertically through all levels of the brainstem. Has clusters of gray matter scattered throughout the pons, the medulla, and the midbrain. And then it occupies spaces between the white fiber tracts and the brainstem nuclei. It has connections with many areas of the cerebrum, and it's more than 100 small neural networks without distinct boundaries. Its networks deal with somatic motor control, where it adjusts muscle tension to maintain tone, balance, and posture. So we're looking at standing up correctly or sitting upright. If you see yourself leaning to one side, we have the somatic motor control that will help with keeping us or pushing us in the opposite direction just to control our balance. essential during body movements. It relays signals from eyes and ears to the cerebellum. It integrates visual, auditory, and balance and motion stimuli into motor coordination. It has a gaze center, and that allows the eyes to track and fixate on objects. It has central pattern regulators, and those are the neural pools that produce rhythmic signals to the muscles of breathing and swallowing. Some more functions. We have cardiovascular control, pain modulation, sleep and consciousness, and habituation. Here we have with the cardiac control. Cardiovascular control. It includes cardiac and vasomotor centers of the medulla oblongata. So it's going to control the heart rate and other things pertaining to the heart. But pain modulation, one route by which pain signals from lower body reaches the cerebral cortex. If you step on a tack or you hit your toe, those signals are sent up to that particular region for pain modulation. And then origin of descending analgesis pathways. Now, those are fibers that act in the spinal cord to block transmission of pain signals to the brain. Our sleeping consciousness, it plays central role in states of consciousness such as alertness and sleep. Injury to the reticular formation can result in irreversible coma. And then we have habituation, which is a process in which the brain learns to ignore repetitive, inconsequential stimuli while remaining sensitive to others. So with the sleep unconscious one, we have resultant or irreversible trauma. That's where various sports come into play, and that's why a lot of athletes or coaches and conditioning coaches are taking a better approach in how various players are supposed to attack their teammates during practice as well as the other team, just to make sure to reduce the amount of concussions as well as comas or injuries that can occur to the brain. Now we have the 5 lobes, which we mentioned earlier. I do have it here again. Not necessarily should have taken it out, but I'm not gonna go over these, but you can delete them from your slides if anything. Okay, so when we look at the cerebral white matter, we have 3 types of tracts. We have the projection tracts and the commissure tracts. With the projection tracts, they just extends vertically between higher and lower brain and spinal centers, and it carries information between cerebrum and the rest of the body. The commissure tract crosses from one cerebral hemisphere through bridges called the commissures, and it must pass through the corpus callosum. Hopefully you guys remember that is that area within the brain that connects the left and right hemisphere. It has the anterior and posterior commissures, and enables the 2 sides of the cerebrum to communicate with each other. Then we have the associating tracts. Those connect different regions within the same cerebral hemisphere. We have long association tracts and short association tracts. The long association tracts, they connect different lobes of the hemisphere to each other. So it's like frontal lobe with the occipital lobe, or the parietal with the temporal or the insula. Then we have the short association fibers, which connect different gyri with a single lobe. So here we have a picture of the various lobes. We have our association tracts. We have our projection tracts and our commissural tracts. Now we have various wavelengths or waves that are read within the brain when an EEG is being performed. Now the EEG is very useful in studying both the normal and abnormal brain functions. Okay, so there are 4 types of brain waves that can be distinguished based on differences in amplitude, and it's read in amplitude MV, and of course frequency in HZ. That's what HZ stands for, frequency. We have the alpha, beta, theta, and delta waves. When we look at the alpha waves, these waves have frequencies of 8 to 13 frequencies hertz, and are recorded especially in the parietal occipital areas. Now they dominate the EEG when a person is awake and resting with the mind wandering. So this is a normal waiting state, and they are suppressed during sensory stimulation and mental tests, and are absent during sleep. Our beta waves have a frequency of 14 to 30 and occur in the frontal and the parietal region. They are accentuated during mental activity and sensory stimulation. So that's still a normal waking state. So your eyes will be open, you'll be performing a certain mental tasks. Now our theta waves have a frequency of 4 to 7, and they are normal in children and in drowsy or sleepy adults, but a predominance in awake adults suggests emotional stress or brain disorders. Our delta waves are high amplitude slow waves. So you see them right here, very slow, with frequencies of less than 3.5. Now infants, they exhibit delta waves when they are awake, and adults exhibit them in deep sleep. A predominance of delta waves in awake adults indicate serious brain damage. So here is a picture of the EEG. We have these various leads that are placed on various aspects of the brain. The temporal, the frontal, of course, in the occipital region, and the occipital region. When you go in for the test, they will always, well, prior to going to the test, they will make sure to inform you not to have anything in your hair. So for people that wear braids or weaves or put oils and stuff in their hair, you will not be able to have them in your hair. Basically, you just have to pull it back in one and go, because they'll have to place these leads on your scalp. It doesn't look like if it's on her scalp, but they have to put them on your scalp. And if you have all these things in your hair, especially with the oil, it will disrupt and give a false reading, which is obviously what you do not want. So sleep is a temporary state of unconsciousness from which one can awake when stimulated. Well, that's some people. Now, once in it occurs in circadian rhythms. And a circadian rhythm, daily rhythmic activity cycle based on a 24-hour cycle or interval. So it is characterized by a stereotyped posture, which is laying down with the face closed, with your eyes closed, and inhibition of muscular activity, which is sleep paralysis. And it resembles coma and hibernation, and except when individuals cannot be aroused from their states of sensory stimulation. Now we know that EEGs are there used to study sleep and its disorders, and occurs in distinct stages recognizable from changes in the EEG. Now we have various stages. We have stage 1, 2, 3, and 4 stages. So this is our awake stage. We see a lot of activity, so the person is active. In stage 1, that's considered to be our drowsy stage. So if a person's feeling drowsy, closing of the eyes, and starting to relax. And the EEG is demonstrated in alpha waves. In stage 2, we have light sleep, during which the EEG declines in frequency. So it starts starting to slow down just a little bit, but increases in amplitude. Occasionally exhibiting sleep spindles from interactions between the thalamus and the cerebral cortex. In stage 3 is moderate to deep sleep, typically beginning about 20 minutes after stage 1. And we have theta and delta waves appear, and vital signs begin to fall. In stage 4, that is the deep sleep, the slow wave sleep, or SWS. And that's because the EEG is dominated by delta waves. The vital signs are at their lowest levels, and the person is difficult to awake. So here we have our stage 1, which I just informed you of, our stage 2, which is our light sleep, our stage 3, where we have both theta and delta waves that are a pair. And of course, our vital signs will decrease. And our stage 4 is where we have delta waves will start to dominate. Now, after about 5 times a night, a sleeper break tracks from stage 3 or 4 to stage 2. So they're going to go to stage 3, 4, and then they're going to backtrack to stage 2. And they're going to exhibit bouts of rapid eye movement, which is our REM sleep. The eyes start to oscillate back and forth. Also called paradoxal sleep, because the EEG resembles the wakened state, but sleeper is harder to arouse than any other stage. The vital signs start to increase. The brain uses more oxygen than when awake. Sleep paralysis stronger to prevent sleeper from acting out dreams. And we have body repairs and regenerates tissues, builds bones and muscles, and appears to strengthen the immune system. That's why they used to tell us make sure we have at least 7 to 8 hours of sleep, so to ensure that things are being repaired, muscles, tissues, and to strengthen our immune system. Now, dreams occur in both REM and the non-REM sleep. Now, the REM tends to be longer and more vivid. The parasympathetic nervous system is very active during the REM sleep. It causes constriction of the pupils and erection of the penis, and as well as the clitoris. Now let me look at the cerebral lateralization. We have the left hemisphere and the right hemisphere of the brain. Cerebral lateralization is a difference in the structure and the function of the cerebral hemispheres. The left hemisphere is considered to be the categorical hemisphere. It's specialized for spoken and written language, sequential and analytical reasoning, math and science, and it breaks information into fragments and analyzes it in a linear way. Our right hemisphere, which is our representational hemisphere, it perceives information in a more integrated, holistic way. Is the seat for imagination and insight, musical and artistic skill, the perception of patterns and spatial relationships, and the comparison of sights, sounds, smell, and taste. Now we're on to our cranial nerves. Now the brain must communicate with the rest of the body. And how's it going to do that? Through our cranial nerves. So it communicates with the rest of the body via our 12 pairs of cranial nerves, in addition to the major input and output via the spinal cord. Now the cranial nerves are numbered from 1 to 12, starting with the most rostral pair, and each nerve also has a descriptive name. Now in terms of cranial nerve pathways, most motor fibers of these nerves begin in the nuclei of the brainstem and lead to glands and muscles. Now some cranial nerves are classified such as motor, some are sensory, and others are mixed. Now the cranial nerve sensory fibers begin in receptors located mainly in the head and the neck and lead mainly to the brainstem. The sensory fibers for proprioception begin in muscles innervated by motor fibers of the cranial nerves, but they often travel to the brain in a different nerve than the one supplying motor innervation. Now, most cranial nerves carry fibers between the brainstem and the ipsilated receptors and effectors. The exceptions are the optic nerve, number 2, and where half of the fibers decussate, and the reticular nerve, which is number 4, in which all the efferent fibers lead collaterally. Now, cranial nerves are usually classified, as I said, as the sensory, motor, and mixed nerves. Sensory, we have 1, 2, and 8. Motor is 3, 4, 6, 11, and 12. And they stimulate muscle, but also contains fibers of proprioception. And our mixed is our 5, 7, 9, and 10. And these sensory functions may be quite unrelated to their motor functions. For example, we have the facial nerve, which is number 7, has a sensory role in taste and motor role in facial expression. So how are we going to even remember all of these 12 cranial nerves? Well, once one takes the anatomy final, very good vacations are heavenly. This will help us to remember. We'll help you guys to remember the 12 cranial nerves. We have olfactory. Olfactory is considered to be a sensory nerve, and is nerves for smell. And if it's damaged, it's going to impair your sense of smell. Now, it can also be tested by determining whether a patient can sense aromatic substances. Our second one, our optic nerve, which is our number 2, CN2. This is a sensory nerve for vision, and it passes out of the cranium via the optic foramen. So here's our optic nerve, passing out through the optic foramen. Its origin is in the retina, and its termination, it starts in the retina, and its termination is in the thalamus and the midbrain, which is in this region. Now, if it's damaged, blindness occurs in part or all of the visual field. It can be tested by inspecting the retina and testing peripheral vision and visual acuity. Our ocular motor nerve are number 3. Predominantly a motor nerve. It controls muscles that move the eyeball up and down and medially, as well as those that control the iris, the lens, and the upper eyelid. It passes out of the cranium via the superior orbital fissure. Its origin is in the midbrain, and it terminates in the somatic fibers to muscles of the eye, with autonomic fibers entering the eyeball to muscles of the iris and the lens. Now, if this nerve is damaged, a patient may have droopy eyelids, dilated pupils, and able to move their eye in some directions. Tendency of eye to move laterally at rest, double vision, and or difficulty focusing, and is tested by looking for differences in pupil size, response to light, and ability to track moving objects. Our number 4 are reticular. Predominantly a motor nerve, and it controls a muscle that rotates the eyeball. So you see where it's located. It doesn't look if it will rotate this eyeball upward and downward. Medially and slightly depresses the eyeball when the head tilts. It passes through the superior orbital fissure. So you see right here, it's passing right through it. Now, its origin is in the midbrain, and it terminates in the superior oblique muscle of the eye. Now, if this nerve is damaged, the patient may experience double vision and inability to rotate the ear, the eye inferolaterally, and the eye pointing superiorlaterally, and may tend to tilt the head toward the affected side. Now, the test is used. It tests the ability of the eye to rotate inferiolaterally. So that's down and out, and superiorlaterally means up and out. So looking upwards, but then up in the corner, the outer corner, not the inner corner, but looking up into the outer corner. And the infralateral is looking down, but in that corner to the left. Well, the outer corner. Then we have number 5, trigeminal. It's the largest and most important sensory nerve of the face and has 3 divisions. It really does. It has the ophthalmic division, and it has sensory function in touch, temperature, and pain sensations from the upper face, and it passes through the superior orbital fissure. Its origin is the superior region of the face, surface of the eyeball, lacrimal gland, superior nasal mucosa, and frontal and ethmoid sinuses, and then it terminates in the pons, which we see right here. Now, if it is damaged, sensation is lost from the upper face, and it can be tested by evoking the corneal reflex, which is a blink in response to light touch to the eyeball. Then we have the second one, which is our maxillary division. This second division has the same functions as V1, or ophthalmic division, but lower on the face. It passes through the foramen rotundum and the infraorbital foramen. So here we have it here. I'm passing through the foramen all the way down. So it terminates. Its origin is the middle region of the face, the nasal mucosa, the maxillary sinus, the palate, and the upper teeth and gums. Then it terminates at the pons. Now, if it's damaged, you'll have a loss of sensation from the middle of the face, and of course they'll have the test the sense of touch pain, and temperature. The third division is the mandibular division. Now it's a mixed nerve with sensory function, the same as the V1 and the V2, but still lower on the face. So you see mandibular division, and it is lower on the face. It also plays a major role in mastication, which is a motor function. Now it passes through the foramen oval, and its sensory origin is the inferior region of the face. The anterior 2/3 of the tongue, but not the taste buds, the lower teeth and gums, the floor of the mouth, and the dura mater. So they have those sensory control over those areas. And of course its motor origin is in the pons. Now its sensory termination is in the pons. Its motor termination is in the anterior belly of the digastric, massetary, the temporalis, the mylohyoid, the pterygoid muscle, and the tensor tympani muscle of the middle ear. Now if it's damaged, the patient may have loss of sensation, impaired chewing. We have success motor functions by palpitating masseter and the temporalis, while subject clenches the teeth and test ability to move the mandible from side to side and open the mouth. Here is our number 6 cranial nerve. This is our abducens, or abducens. It's predominantly a motor nerve, and it controls a muscle that turns the eyeball laterally. Now that's moving it outward, looking outward. It passes through the superior orbital fissure. You see here. It originates in the inferior aspect of the pons, and it passes through the superior orbital fissure, and then it's going to terminate in the lateral rectal muscle of the eye. Now, if it's damaged, the patient is not able to turn the eye laterally, and at rest the eye turns medially, and they usually test for lateral eye movement. Number 7, or CM7. It is a mixed nerve. It has sensation, function, and taste, and is the major motor nerve of the facial muscles. It has 5 predominant branches: our temporal, our zygomatic, buccal, our mandibular, and our cervical. We can see them here in this diagram. I tried to find a good diagram for you guys to see these. So we have our temporal branch here. We have our zygomatic branch. Then we have the buccal branch. We have our mandibular branch here. And then we have the cervical branch. So these are the 5 main branches of the facial nerve. Now its sensory origin is the taste buds of the anterior 2/3 of the tongue, and its motor origin is in the pons. Its sensory termination is the thalamus, and its motor terminations are in the muscles of the jaw, middle ear, and facial muscles, with autonomic fibers in the salivary glands, tear glands, and nasal and palatine glands. Now, if it's damaged, the patient may have an inability to control facial muscles and facial sagging due to loss of muscle tone, plus a distorted sense of taste, especially for sweet flavor. Our number 8, our CN8, is predominantly a sensory nerve, and is the nerve of hearing and equilibrium, but also has motor fibers that tune for sense of hearing. Now, its sensory origin is the cochleae, vestibule, and the semicircular ducts of the inner ear, and its motor origin, Pons again. So here we have the vestibular nerve, the cochlear nerve, and the semicircular nerve. These are their places of sensory origin. Okay. Now, its sensory termination consists of fibers for hearing that end in the medulla, and those for equilibrium that end at the junction of the medulla and the pons. Its motor termination is the outer ear cells of the cochleae of the inner ear. So here we have this the area for termination. Now, if it's damaged, the patient experiences nerve deafness, dizziness, nausea, loss of balance, and an inability to an involuntary oscillation of eyes from side to side, called nystagmus. And you test for hearing, balance, and inability to walk, just to see if the person may suffer from that type of disorder. Our number 9, our glossopharyngeal, is a complex mixed nerve with numerous sensory and motor functions in the head, neck, and the thoracic regions. It passes through the jugular foramen. Its sensory organs include the pharynx, middle and outer ear, a posterior 1/3 of the tongue, including taste buds, and the internal carotid artery. Its motor origin is the medulla oblongata. Its sensory termination is the medulla oblongata. Its motor terminations include the parotid glands of the posterior tongue, and the stylopharyngeal muscle. So here, this is where they're going to be terminated. Here's our parotid glands, posterior of the tongue, and here's this muscle, the stylopharyngeal muscle. Oh, sorry, right here. Pharyngeal muscle. I'm pointing to the wrong area. Sorry. Now, if it's damaged, a person has impaired swallowing, loss of bitter and sour taste, and of course they'll test for a gag reflex, ability to swallow and cough, and note any type of speech impediments. Now, the vagus nerve, which is our CN10, this is a mixed nerve and has the most extensive distribution of any cranial nerve, supplying organs in the head, neck, and most viscera of the thoracic and the abdominal pelvic cavities. It passes through the jugular foramina. Now, its sensory origin includes the thoracic and the abdominal pelvic viscera, the root of the tongue, the pharynx, larynx, epiglottis, outer ear, and dermata. Its motor origin is the medulla. Now, its sensory termination is the medulla oblongata. Its motor termination include the tongue, the pharynx, lungs, heart, liver, spleen, digestive tract, kidney, and the ureter. If it is damaged, a patient may exhibit hoarseness or loss of voice, impaired swallowing, and gastrointestinal motility. Our number 11, our accessory nerve, predominantly a motor nerve involved in the head, neck, and shoulder actions. It is it's unusual in that it does not arise entirely from the brain, but in part from the cervical spinal cord, and it passes through the jugular foramen. So this is going to be in the spinal cord. No, its origin is the medulla oblongata and spinal cord region. So here we have the spinal cord, and we have the medulla. Remember, that's our pons and our medulla. So this is number 11. Do not forget number 11. Its origins in the medulla and the spinal cord segments, C1 to C6. Now, its terminations are in the palate, the pharynx, the trapezoid, and the sternocleidomastoid muscle. There's basically muscles in the neck, and there's muscles in the back of the neck. Hopefully you guys remember that from 201. Now, if it's damaged, a patient exhibits impaired movement of the head, neck, shoulders, and difficulty shrugging on affected areas. May have paralysis of the sternocleidomastoid, causing the head to turn toward the injured side. And usually they'll test it just by rotating the shoulders and by rotating the head and shrugging the shoulders. Our last one, our number 12, is the hypoglossal. The hypoglossal nerve, predominantly a motor nerve, it controls the tongue movements. Now it passes through the hypoglossal canal. The hypoglossal canal right in here. Its origin is where? What's this structure? This is the medulla oblongata, and it terminates in the intrinsic and extrinsic muscles of the tongue. So here's our extrinsic, and here's our intrinsic muscles. Now, if it's damaged, we have impairment of speech and swallowing with deviation of tongue that will move toward the injured side. And we have atrophy, not hypertrophy, atrophy, or an inability to protrude the tongue if both left and right nerves are damaged. And to test it, they'll have the person move their tongue from left and right, up and down, just to see how the nerve functions. So here is a summary of the 12 cranial nerves and their functions. The olfactory, number 1, is sensory. The optic nerve, it's sensory. The number 3, CN3, the ocular motor, is motor. CN4, the tracheal, is motor. Number 5, the trigeminal, is both motor and sensory. Number 6, the adducens, is motor. Facial is both. Auditory, also called the vestibulocochlear, is sensory. The glossopharyngeal is both sensory and motor. The vagus is both. The spinal is motor, and the hypoglossal is motor. Please remember the functions of these cranial nerves, as well as their order. They have to be in order. If I ask you to list them, or certain questions are asked pertaining to the order of these nerves, you have to know the order. It's very important, and as well as the functions and where they originate and terminate. Now, a few cranial nerve disorders. A trigeminal neuralgia. We already know where they originate and where they terminate. This is a recurrent episodes of intense stabbing pain in the trigeminal nerve area near the mouth or nose. Now, pain is triggered by touch, drinking, or even washing the face, and treatment may require cutting the nerve. Also, some other type of treatment would be surgery. Sometimes we think we may have a tumor resting on the nerve, preventing you from causing this pain to occur. So they will actually perform a surgery to remove the tumor to ease the pressure on that pain. A lot of times, depending with the nerve where exactly the tumor or the pressure is being applied to the nerve, that pain would reside or persist, just say all day long, with pain radiating from your jaw, the upper and lower jaw, your entire face, even in your parietal and in your frontal lobe. And it is extremely painful. Sometimes people will describe it as a brain freeze type of pain. We know we've had a brain freeze once in a while. We've had a brain freeze at least once in our lifetime. So just picture that all day long on just one half of the brain. Sometimes if it's not severe, or just to ease the pain, they will give you pain medication just to ease it. And you'll have to take it maybe on every 4 hours, depending on how severe it is or how often you have to tolerate it. But they'll definitely do an MRI just to see if there's any obstruction or any type of pressure placed on that nerve before they do any surgery. So you'll see your primary care physician, and then they'll just send you over to your neurologist just to confirm what their prediction may be. Then we have Bell palsy. It's a degenerative disorder of the facial nerve causing paralysis of facial muscles on just one side. Now, may appear abruptly with full recovery within 3 to 5 weeks. So here we have you have droopiness of the person's face because it's paralysis. So these nerves are not stimulating the muscles on that one side of the face to contract. So you have that droopy look. So if you do not have any other questions, if you have any questions, please go to Blackboard and post your questions and maybe answer some other people's questions pertaining to this chapter. Okay, I know it's very long and very intense, very detailed, but you have to set aside some time to go through and read this information and even make your own notes, ways that you can study and remember the cranial nerves and the various structures and functions of the brain itself. I'll see if I can post a video for you guys. I saw one on the internet with a song to help you guys remember the cranial nerves. So good luck in your studying.